Has started.
Friends and colleagues, we're going to start this grand rounds with a remembrance. Two people very close to our hearts. As some of you know, Stuart Urbach passed just a few days ago. Stuart Urbach actually received his residency in internal medicine at the old Louisville General Hospital, which is now our Able Administration building. And that was from 1949 to 51. He was only in private practice a few years, and then he came back and has been on faculty since 1955. We aren't completely sure. The dean will be checking. He may be the longest tenured faculty member in the history of the University of Louisville. In the last 5 years, he's been teaching the history of medicine, and I ran into him in the elevator not short of a month ago. So it's with a deep sadness of his passing, and the Department of Internal Medicine is going to establish a lectureship, at least in his honor. Also, a week ago, and you may know that Hank Wagner also passed, and Hank Wagner joined the administration of Jewish Hospital in 1972, and then rose to the ranks of president and CEO by 1980, and he served for 30 years in that role. So 2010, I remember him as well. He built Jewish Hospital, he and visionaries like him, and a lot of endowments, and that system became a 10-hospital system over 2 states. Jewish Hospital is known for the world's first successful hand transplant, for Kentucky's first heart, lung, liver, and pancreas transplant, and also the world's first implantable artificial heart. So it makes sense that the endowed fund that will be established in his name will be the Hank and Donna Wagner Endowment for Excellence in Heart Care. And with that, Dr. Sohi just let us know that today may also be a historic event if we are successful in recruiting Dr. Dinesh Kalra from Rush University to be our division chief. No pressure there, Dinesh. You received your education at a lot of esteemed institutions, including Baylor, Ann Arbor, Michigan, Cornell, New York, and now at Rush, he serves as the Director of Advanced Imaging, having established that subsection. He is certified in CT, CMR, and nuclear. He has focused research interests and does a lot of clinical trials as well in infiltrative heart diseases. And remember, last week we had Dr. Eckel talking about cardiometabolic syndrome. Well, Dr. Kalra has established a lipid clinic, so he's far along on that pathway of understanding the interrelationship between lipid disease and cardiovascular disease and metabolic syndrome. Dinesh is nationally recognized. He serves on multiple editorial boards, and again, he has multiple clinical trials and a very impressive CV. And with that, Dinesh, I'm going to say thank you for coming, and we are looking forward to your presentation this morning.
Thank you. Thank you for those kind words, and it's an honor to be here, and I'm really excited to meet a lot of you folks today. So my talk today is going to be on clinical imaging case-based applications. I have no disclosures relevant to this talk. So I want to start off with a little story, and you may have heard of this poet by the name of John Sakes, who in the 1800s wrote a fable about how 6 blind men come upon an elephant, and each one tries to describe the elephant. The first one touches his tail and thinks it's a rope. The next one touches the leg of the elephant and thinks it's a tree. Yet another one argues that it's a spear. And while each one of them was partially correct from their own vantage point, in totality they're wrong. And I think the moral of this story, as it applies to my field, is that when you're looking at something and evaluating something, if you have only a piece of the information, it can lead you to incorrect conclusions. And so what I think I want to do in the next 45 or 50 minutes is talk to you about heart disease and imaging of heart disease and how, in order to get a proper diagnosis, sometimes you need to do multimodality imaging, i.e. gather more than one facet of information and put it all together. Now, that doesn't mean that you have to use every tool available in that toolbox. We have a myriad tools, as you see on this slide. We have echocardiography that is really the furthest developed. That includes transthoracic and transesophageal echo, including 3D and color. We have computed tomography of the heart, along with newer techniques in that you'll hear about today. We have cardiovascular magnetic resonance, and we have nuclear imaging, including SPECT and PET. And it's my hope that at the end of this talk, you'll get an appreciation of which tool can be applied to which disease state. It's not necessary to stack up one test after another, but perhaps to get an understanding of, in this disease process, if I choose tool A and tool B for imaging my patient, that's going to give me the best diagnosis. I'm not going to talk about invasive imaging techniques such as cardiac catheterization or intravascular ultrasound. I'm going to focus mostly on advanced cardiac imaging that includes CT, MR, and PET, all while staying cognizant of the fact that we live in a cost-conscious environment today, and we have to select wisely, and that's the campaign that's put forward by the American Board of Internal Medicine and the ACC to choose wisely when you're selecting tests for your patients. So I hope to do this by giving you a potpourri of cases that I've seen over the past 10, 15 years and get you a sense of how we evaluate cardiac disease with imaging. So here's my first patient. It's a 63-year-old man who comes in with multiple infarcts and emboli. So he presented to the ER with right-sided weakness and aphasia. A CT of the head showed a new stroke in the left middle cerebral artery. Unfortunately, that same night, within a few hours, he also developed a cold right foot, and he needed to be taken for an emergent thrombectomy of one of his arteries in the leg. His EKG showed sinus tachycardia, no ischemic changes, but his troponin did peak to 9. And so the next step was, what do we do? And so we obtained an echocardiogram, and as you can see on the echo, there is hypokinesis of the distal wall of the left ventricle, as well as apical akinesis. And there's this echogenic mobile structure that you see in the apex of the left ventricle. When you give contrast, you'll notice that there's no contrast uptake in this, and so it's an avascular structure. He was started on a heparin drip, and he started having right-sided abdominal pain, so he went down for a CT, and that showed a renal infarct. So now this gentleman has had emboli to his brain, to his leg, and to his kidneys, and I think we have a source of the embolus. This cardioembolus is arising from what looks to be a thrombus. And we wanted to investigate what was the cause of his non-STEMI, because his troponin had gone up to 9. So instead of taking him to the cath lab, we did a coronary Ct angiogram, and you can see there's mild plaque in the left anterior descending artery, but really he had non-obstructed coronaries otherwise, so we saved him from going to an invasive angiogram, given all of his problems that he was having otherwise. And then he did clinically okay after that for a few days, and after we wanted to investigate what the cause of his depressed ejection fraction and his thrombosis was. So we obtained a cardiac MRI, and much to everyone's surprise, the good news was that his heart muscle function had now recovered. His EF is now 70%, and you'll see that the apex of the left ventricle is now clean. That thrombus is no longer there, so it is resolved in heparin. And we obtained some further imaging. The picture on the left shows you a technique called late gadolinium enhancement, which looks for scar. And if it's black, it means the myocardium is healthy, so there's no scar in this left ventricular myocardium. But the picture on the right shows you some brightness, so-called hyperintensity of the myocardium, which signifies myocardial edema on what is called T2-weighted imaging to look for edema. And so this patient actually turned out to have something called Takotsubo cardiomyopathy or stress cardiomyopathy or broken heart syndrome. And the word Takotsubo comes from Japanese, where it means an octopus pot because of the resemblance of the left ventricle in this disease state to a pot that Japanese fishermen used to trap octopi. And so you'll notice that the base of the left ventricle here is narrow and contracts well, and the distal segments and the apex are ballooned out and do not contract well. And so this typical echo appearance is very useful in making the diagnosis. Now, classic to this syndrome is generally that you have very prominent chest pain, you have very prominent EKGs, and but you have normal coronaries, and you do not have much in the way of a troponin leak. And these people generally recover uneventfully, as this gentleman did. What was unusual about this case, however, is that most of these cases were first described in elderly women, especially after they got some bad news, for example, a big fight or the death of a loved one, etc. And this gentleman obviously is a male, and he had no triggers. Sometimes in men, the trigger can be intense exercise. He had none of that. And then it's unusual to have multiple emboli everywhere, but he recovered uneventfully despite all those sites of thromboembolism. So again, it goes to show you, if we had just stopped at the echo, we would not have gotten information about what was going on with whether or not he had any scar tissue and how his heart recovered. And we were able to clinch the diagnosis because of the typical MRI findings also in this patient. And the CT saved him a trip to the cath lab because even though his troponin had gone up, we were able to demonstrate that the etiology of that was not ischemic. It was from direct injury to the myocardium, which is felt to be from increased catecholamine levels in this disease. So the next case is somebody I saw in the lipid clinic. This is actually a 61-year-old gentleman who is a surgeon at our institution, and he came to see me because his father had a heart attack at age 49, and he himself is fairly healthy. His blood pressure is normal, he exercises, and if you take a look at his lipids, they're very good. And if you plug in all of these numbers into the American College of Cardiology pooled cohort equation risk calculator, you arrive at a 10-year risk of him having a heart attack or stroke or dying from cardiovascular disease of 5%. And most recent guidelines recommend that if the risk is less than 7.5%, generally you can manage the people with diet and you don't need to put them on medications necessarily. And so that was his question, I'm healthy, my risk isn't very high, so do I need to take a statin? But in the back of his mind, his family history was certainly concerning and was a lurking thing that he wanted us to address. So we said, well, we have other tools. We're not just going to use demographic factors. We can actually do something else to assess your risk even better. So two of the things that we commonly use are something called Lp(a) levels, which is a serum biomarker, much like LDL, and then calcium scanning, coronary artery calcium scanning. So we obtained both of those, and his Lp(a) was 28 nanomoles per liter, which is normal, but his calcium score was moderately elevated at 275 Agatston units. This is his calcium scan, and this is a non-contrast CT, just looking at the heart, so no IV is needed, no contrast is given, and you basically measure for the amount of calcium that's present in all three coronary arteries, and that's colored for you here, but calcium appears bright white on these scans, and so it's easily quantifiable. And you can see he's got calcium in all coronaries, LAD, circumflex, left main, and his total score is 275, which puts him at the 75th percentile for a man his age. And if you plug all those numbers, including the calcium calculator now, into this MESA risk calculator, you get a risk of 9%, almost double his prior risk. And so based on that information, we know that he's at higher risk than he initially thought. This is data that our group published in 2014, looking at the relationship of calcium and the probability of finding at least one tight coronary stenosis, defined as a lesion more than 70% stenotic. So the higher your calcium score, especially calcium scores over 400, which is severe, you have a 40% chance of having at least one blockage that's 70%. We have enormous amounts of data about the prognostic value of calcium scoring now. This is data from the MESA, the Multi-Ethnic Study of Atherosclerosis, which was published in 2008. And now we have a database of almost 20,000 patients with much longer follow-up of 10 to 15 years. And again, it goes to show the same point that the higher your calcium score, the better your risk. So calcium scoring really has now become a favored technique to further refine risk, especially in people where you're not so sure what their risk is, just looking at their demographic factors alone. There's an adage we commonly use in preventive heart disease, which is if you're trying to address whether or not somebody has coronary plaque, then why are you looking at surrogate markers like smoking and hypertension alone? Those are okay, but they don't tell the whole story. If you had a chance to actually visualize the plaque, then that's the best way to assess the disease burden. And so these have now, that technique has now made it to the guidelines. These are 2017 guidelines from the Society for Cardiovascular Ct. Basically, any asymptomatic individual where the pooled cohort risk equation tells you that there are intermediate risks, defined as a risk of 5 to 20% over the next 10 years, you can use a calcium score to further help you along in determining whether to escalate their risk or to downgrade their risk. Obviously, if their risk gets escalated, like in this gentleman, then you can offer them lifestyle plus statin therapy. And if the risk gets downgraded, then you can tell them that there's no need to take a statin at this moment. You can also repeat calcium scores in about 5 years. If the score today is 0, then you can repeat in 5 years to see if it'll change management then. If the score goes up rapidly or it's positive then that would be another reason to start the patient on a statin at a later date. And then there's recommendations about how every non-contrast CT of the chest, even if it's done for lung cancer screening, should have mention of whether or not there's coronary calcium. Because believe it or not, when we see these CTs of the chest, if you have a lot of calcium, what's going to kill the patient is not the non-cardiac findings, but the presence of calcium that will lead to heart disease. So that's why it's so important to not gloss over the cardiac findings on a chest CT. There's also guidelines from the American College of Cardiology that are in sync with what I just said. Basically, anytime you have somebody with intermediate risk, you should measure a coronary calcium score that gets a class 2A recommendation to guide that patient-clinician risk discussion and initiation of statin therapy if needed. So this patient, the surgeon, he had moderate calcium. His 10-year risk was 10% rather than 5%, and so he was started on atorvastatin, 40 milligrams, and he's doing well after that. What we've done in our lipid group is really expand the use of calcium scoring, just like I showed you, to not just individuals where you feel like there's other risk factors which are not captured in the Framingham risk tool, such as family history. Another very big one is ethnicity, and that's got to do with genetics that we don't fully understand, but we all are aware that South Asians are at very high risk of cardiovascular disease starting in their 30s and 40s. So we have a big South Asian program called the SAUCE program, South Asians in the United States, and we have partnered with the National Lipid Association to come out with guidelines of how to screen and treat these people. That will be published this year, hopefully this summer. And then we have also come up with the recommendations that people who are secondary prevention, i.e. a South Asian who's already had heart disease or a heart attack, we really need to shoot for lower, more aggressive targets in these people of less than 30, LDL less than 30. Remember that the American guidelines say less than 70 is okay. The European guidelines at the moment say less than 55 and very high risk, and we feel that this group is at such tremendous high risk that you should aim for even lower. Another area of research of our group, especially when it comes to imaging, has been plaque imaging, because it's now possible with coronary CT data sets to look at the composition of plaque and to quantify which plaque has high lipid burden, shown here in red, what's more fibrous, shown here in green. And so you basically get a virtual histology of the plaque based on the imaging data, and then you can follow this serially and carry out various interventions, such as a vegetarian diet or novel drugs, to see if that plaque burden is changing and if you're stabilizing this so-called vulnerable plaque, which has a lot of lipid and a very thin core fibroatheroma. One of the risk markers I talked about recently was Lp(a). This is a new molecule that's getting a lot of attention, and it's essentially a lipoprotein that contains LDL, but it also has other atherogenic properties because it carries oxidized phospholipids, and so it does three things. It can invade or penetrate into the subendothelium, much like oxidized LDL does, and carry out atheroma formation that way. But on top of that, it's also prothrombotic because it bears homology to plasminogen, and it's also pro-inflammatory. So it's got a triple whammy, so to speak, when it comes to atherogenesis. And now we know that about 20% of the United States population has high levels of Lp(a), shown here in red, about 50 milligrams per deciliter, or which also translates to 30 nanomoles per liter. And the higher your Lp(a), the higher your risk of cardiovascular disease in a log linear relationship. I think what we've learned over the past 5-10 years is that when you see people who are healthy, who have no other risk factors and are coming in with a heart attack, as shown here in this example of Bob Harper, who is a very fit athletic trainer who used to work on the TV show The Biggest Loser, he had a heart attack in his late 40s without any risk factors. Those are the kind of individuals you need to screen for high Lp(a) because most of them have it. Well, what do we do about it? If you find it, can you lower it like you can lower LDL with statins? Turns out now you can. There's several products that are in development, and one of these is an antisense oligonucleotide that can lower it by about 80%. And there's now a phase 3 clinical trial that we're getting ready to participate in, and this will be looking at outcomes. So patients with high Lp(a) and established atherosclerotic cardiovascular disease will be followed, randomized to this subcutaneous injection of this medication called pelacarsen, and the other people will be randomized to placebo, which includes statin, and we'll follow them for 5 years looking at clinical outcomes. And so that data is expected to be read out in 2024, and so this is an exciting area of lipid research today. All right, changing gears, I'm going to talk about what you and I commonly see in the emergency room on a daily basis. So this is somebody who comes into the ER with chest pain, a 44-year-old man, but he has a history of cocaine use. He hasn't used in 5 days, and we proved that on his U-Tox. But his EKG is concerning. As you can see, there's ST elevation in the anterior leads. There's biphasic T waves. This is something called a Wellen sign, after an electrophysiologist from the Netherlands who first described this, and it generally connotes proximal LAD occlusion. So what would you like to do? Should we take him for an urgent cath? Should we do a stress test? Should we do a CT? He's currently chest pain free, and his troponin is negative, so there's no reason to rush him to cath right away, so we elected to do a coronary CT. And as you can see, his coronaries are clean and beautiful. There's no blockage or atherosclerosis anywhere. And so this modality, now coronary CT, has really been well established, and it's come of age in the evaluation of chest pain in the emergency room. This was one of the earlier trials released about 10 years ago called the CT Stat. Since that time, there have been several other trials, another one called Akron PA, which came out the year after that, and the third one was the ROMICAT, again confirming the value of CT in acute chest pain. Not only is CT safe and effective, you'll see that the ACS missed rates are quite small and comparable to the usual standard of care, but it also reduces the length of stay for patients. So you can get people out sooner from the emergency room. Our patient was discharged the same afternoon, and it reduces costs in the emergency room. So a lot of big hospital systems have gravitated away from doing the usual protocol of admitting people overnight and doing a stress test in the morning to doing a CT right then and there and getting the patient out of the hospital and freeing up ER beds. So far we've talked about CT in stable chest pain patients. You know, you need to have a normal troponin and a normal looking EKG. Well, how about we expand the horizons of CT? Could you do it for somebody with a non-STEMI? Remember that non-STEMIs are traditionally treated by taking people to the cath lab. Well, we have a very powerful trial now that's just come out called the Verdict trial, which investigated whether taking people to the cath lab very early at 2.5 hours median versus taking them on day 2 or 3, median of 59 hours, whether that changed the patient's outcome at 1 year. And it turns out that it's okay to wait for 2 or 3 days to take people to the cath lab. You don't need to rush and take them right away. That was the primary intent of the trial, but within the trial was also constructed a second arm looking at whether CT done prior to the invasive angiogram would be able to give us answers. So they wanted to look at 2 things. Is CT done in the emergency room for patients with non-STEMI accurate enough to not miss findings? And 2, is it useful clinically to avoid people from going to the cath lab? And it turns out CT was very accurate. You see the sensitivity, specificity, and accuracy here. It's all over 80-90% compared to invasive angiography. But more importantly, this is data released last week, hot off the press, showing that the prognostic value of CT was very good. In fact, in this model, even better than that of invasive coronary angiography. So this doesn't mean that CT is going to supplant CATs for non-STEMI, but it's useful for some patients. And even if you can prevent a quarter of your patients from going to the cath lab when they don't need it, and you can stop after the CT, that reflects a big advance in this field. So I think that's where we're going. We're going to see the more universal use of non-invasive tools such as CT for the diagnosis and evaluation of not just stable chest pain, but also now for acute coronary syndromes. So my third case is a medical student who presented with a cardiac mass. This is a 35-year-old male who's originally from Haiti, and he's in medical school at one of the places in Chicago. And he saw his primary care doctor for palpitations. And the doctor reassured him and said, "You have medical student coffee syndrome. You drink too much coffee." And his wife actually happens to be a cardiac care nurse at our institution, and she requested that he undergo an echocardiogram. She just had some premonition that something was wrong. And what does a good husband do? He listens to what his wife tells him to do. So he undergoes this echocardiogram. And so lo and behold, in the echo, we saw something very surprising. There was this large anechoic mass in the left ventricular apex. And we wanted to investigate it further. So we got a cardiac MRI, and you see that there's a 4-centimeter cystic appearing mass in the wall of the left ventricle. And we wanted to make sure there was no coronary compression, so we underwent a CT, and you can see that it's a hypodense mass in the myocardium, and it's not compressing the left anterior descending artery. So we were left with a broad differential. This is a left ventricular cyst. So we're thinking, is this hydatid disease? Is this teniasis? Is this trypanosoma, Chagas disease? And so we sent serologies for everything. And the diagnosis actually was cysticercosis. He had pork tapeworm. So this gentleman had traveled to Haiti a few months ago for vacation, and he may have at that point eaten some undercooked pork. And for those of you interested in microbiology, this is what the pork tapeworm looks like. It's got a series of hooks on its mouth called the scolex, and it attaches to the intestine, and it lays eggs, and then those eggs can develop into cysts. And so the cyst, in his case, latched on to the heart muscle, but you can typically get cysts in the brain, in the eye, in the skeletal muscle. And so luckily for him, he was treated with oral albendazole, and this is his repeat echo after that. You'll see that the cyst has completely resolved within 2 weeks after treatment. And so he had a wonderful outcome, but it shows you how multimodality imaging in his case was very helpful in arriving at the correct diagnosis. Another case of somebody with chest pain. So this is a 45-year-old woman who comes to the hospital for atypical sounding chest pain, and the medicine team ordered a dobutamine echo in her because she was not able to run on a treadmill. And during the dobutamine echo, the fellow notices that she's having typical angina, and then the EKG shows ST elevations inferiorly, and the echo shows inferior akinesis. So the test was immediately stopped, and she was given IV metoprolol, and then she starts having salvos of non-sustained ventricular tachycardia. So she was emergently taken to the cath lab because of that, and you'll see that her left system is completely normal. And the right coronary itself is normal, but you'll see that the catheter has some difficulty in engaging the right coronary artery. And so we got suspicious that this right coronary artery may have an anomalous origin. And to further define that, she underwent a coronary CTA, and here's an axial CT showing you the origin of the right coronary artery from the opposite cusp. So the picture on the right shows you that the right coronary normally arises from the cusp on the right, and here it's coming from the cusp on the left, where the left main normally arises. So this is an anomalous RCA arising from the left coronary cusp, and it can take various routes. In this patient, it was traveling in between the aorta and the PA, and the reason that's dangerous is because when the cardiac output increases during exercise or during dobutamine infusion, it can get compressed between these two vessels, and that's likely what happened in this woman with dobutamine. Furthermore, the utility of CT is seen here. On the angiogram, which is a luminogram, you only see the inside of the vessel. Here you can actually tell that the origin of the vessel is slit-like, and the vessel travels within the wall of the aorta for a short distance before it actually comes out. That's called an intramural course. And all of those things are bad prognostic features, and they predispose to heart attacks and ventricular tachycardia and sudden death in these people. So she had a surgery done to correct this defect, and since then has done well. So CT has a class 1 indication for the evaluation of anomalous coronaries. So even though her presentation was atypical, the dobutamine induced ischemia in this anomalous coronary artery, which had not been picked up for 45 years, and she was asymptomatic from that, but any kind of increased stress brought out ischemia, and that was the reason for correcting her. Okay, talking along the same lines about coronary disease, we see people with intermediate lesions all the time, and so we often are in a quandary of whether or not to stent these lesions. So we have a 63-year-old woman here who has dyspnea and chest pain, and she undergoes a stress test, which has ST depression and angina, but we're not able to see any wall motion abnormality on the stress echo. So she undergoes a CT to further clarify it. Unfortunately, there's a lot of calcium in the proximal RCA, which is one of the pitfalls of CT. When you have so much calcium, it's difficult to evaluate the lumen within, and she also has non-calcified plaque next to that. Now, we employ another technique that we use commonly called Ctffr to see if this moderate lesion of 60 to 70% is actually ischemia producing, and I'll talk about this in a second, what this technique does. But the Ctffr is positive, i.e. it's indicative of ischemia. A value of less than 0.8 is abnormal, and her value was below that. So she goes to the cath lab and had a lesion visualized again on invasive angiography. The IFR was abnormal, again, confirming what we saw in the Ctffr, and then she had a successful placement of a zotorolimus eluting stent, and since then has been asymptomatic and done well. Now, Ctffr can be used to evaluate not just if a lesion is ischemia producing, but it can also help the interventionalist before going to the cath lab to see if stenting a lesion virtually. So on your computer screen, you deploy a stent by animation, and then you see if that stent deployment will relieve the ischemia for this patient. So this is really virtual stenting. And the reason to do that is mostly in cases when you have tandem lesions, one proximal and one distal, it helps the interventionalist understand which is the one which is causing more of the ischemia. If you can fix the proximal lesion alone and get away with fixing that entire artery, then you can spare the patient from getting 2 stents. And so this sort of virtual stenting allows you to say, okay, if I put in a stent only in lesion A proximally, will that fix the flow to the rest of the vessel? If so, yes, then I can get away without putting a stent in lesion B. And so this virtual stenting is not FDA approved yet, but it's coming down the line, and it'll be useful to, even before taking patients to the cath lab, to see if they'll benefit from that. Now, when we deal with chest pain in the office, one of our common problems is that stress tests really underperform in that area. And this seminal study from 2010 really showed us that carefully by looking at a very large database of almost 400,000 patients. who had a positive stress test and then were taken to CAP. And it's really surprising that 2/3 of the patients with positive stress tests who underwent a CAP after that had no obstructive coronary disease. Even perhaps more worrisome is that 28% of patients where the stress test was negative, but subsequently they ended up needing a CAP for some clinical reason, did actually have coronary disease that was missed on the index stress test. So just a very bad report card for stress testing in general. And from the same study, you'll see that the bars show you that the frequency of finding obstructive disease was no different, whether your stress test was positive, negative, equivocal, or if the patient never had a stress test in the first place. So really, it's gone to show us that stress tests are useful when they're frankly positive, so when patients have tremendous angina or tremendous EKG changes. But for the vast majority of our patients, it's really no better than flipping a coin. And that's what's led the drive to investigate other technologies such as CT. I'm showing you here data from a trial called CONSERVE, where CT was evaluated as a gatekeeper to CAP. So if you do CT for patients with chest pain before they go to the cath lab, you can avoid unnecessary CAPs in a lot of these patients and still keep the patient safe. You'll see here that the MACE rates, the major adverse cardiac event rates, were same in the arm that got direct to CAP, direct invasive coronary angiography, or who had selective angiography, i.e. they first got a CT, and if the CT showed a lesion, then they progressed to CAP. Furthermore, you were able to avoid unnecessary revascularizations by 41% in this technique, and you were also able to cut down costs using this technology. So really, a lot of institutions across the world and guidelines have focused on the primary role of CT in investigating patients with chest pain. In fact, in the UK, they've recommended that every patient with chest pain first undergo a CT as opposed to a stress test. And if the CT is positive, then you should look for Ctffr. And if that's positive, then they go for CAP. And I'll tell you this, that the US guidelines are in revision at the moment and are likely expected this year. And they're, again, going to very strongly position CT as your first-line test for chest pain investigation because of all the data I've shown you. To support that even further, this is a trial that was published about 3 years ago called the SCOT-HART trial, where in Scotland, investigators studied 4,000 patients with chest pain who were randomized to CT-based testing versus stress testing. And for the first time, they were able to demonstrate that an imaging technique is able to improve outcomes of patients. And you may ask me, well, how is that even possible? How does deploying or using a CT as first line for checking my patient with chest pain translate into better outcomes? I haven't done anything different in terms of management. How is it possible that an imaging tool is improving my patient's outcomes, less MIs and less cardiovascular death? Well, it turns out it's very simple if you think about it, because when somebody gets a stress nuclear, it's a binary test. You're either positive or you're negative. If you're negative, it's ascribed to musculoskeletal pain. You go home. You never see a cardiologist again. But if it's positive, in the sense that if the CT shows non-obstructive plaque, even if there's no tight stenosis, the visualization of non-obstructive plaque engenders further changes. So the patient sees that, they're more committed to lifestyle changes. The doctor sees that, they put the patient on aspirin and statin, and then they become a cardiac patient. They follow up with the cardiologist because of those findings, and that's what translates into a low rate of cardiovascular death and MI. And that's, I think, perhaps the biggest contribution of CT is not just the determination of obstructive disease, but the picking up of non-obstructive disease that is down the road going to be more troublesome for the patient. I talked a little bit about Ctffr. This is essentially using computational fluid dynamics to model hyperemic flow in the coronaries. So without putting a catheter into the coronaries, you can assess whether or not flow is impaired, and you can get a model of the heart with all three coronaries and check the fractional flow reserve along any point in the coronary tree. And if it's abnormal, then you know that a stenotic lesion is producing ischemia. So we're part of a multi-center trial called the PRECISE trial that is investigating this Ctffr technology and the study of patients with chest pain, and the results are expected next year, looking primarily at cardiovascular outcomes in these people randomized to a CT-based technology with FFR versus usual standard stress testing techniques. No talk on CT would be complete without talking about its role in structural interventions. I'm sure you use CT all the time before Watchman procedures. These are left atrial occlusion devices that we put in patients who have atrial fibrillation and can't be on anticoagulation. The device goes in the left atrial appendage and occludes it. And the reason CT is so useful here because it gives you a three-dimensional depiction of the appendage. And so we've used words such as windsock morphology or a cauliflower morphology of the appendage. For some reason, cardiologists love making resemblances of anatomical structures to food. There's cactus appearance or broccoli appearance. And so here you can see a multi-lobed appendage, which is seen really well on CT. And before taking the procedure to the lab, you can measure the ostium and the length and give dimensions and plan what kind of a device you want to put in. And here the device that was chosen based on the CT data set was actually bigger than what the transesophageal echo would have predicted. So CT has become very useful in these kind of people. We can also use it for valvular heart disease. Obviously, echo stays number one for valvular heart disease, but everybody who undergoes a TAVR procedure will have a CT done beforehand to see what the size of the annulus is and what needs to be done in terms of access, iliofemoral anatomy, etc. We're going to talk about a case of valvular heart disease that we picked up further defined with CT. It's a 75-year-old woman with lung cancer who came in again with elevated troponins, scattered cerebral infarct. She was a little confused, which is what put her in the hospital. She had no fevers, and her cultures were negative, but an echocardiogram did show vegetations on a mitral and tricuspid valve. So as I said, something was off about this case. She had no fever, no vegetations, no fever, negative cultures, and no risk factors. We got a coronary CTA and a cardiac CTA. The coronary CTA showed normal coronaries, so we were able to exclude a primary ACS event. This was type 2 non-STEMI, and we were able to confirm the vegetations on CT. Here you can see that this was a large vegetation on the anterior mitral leaflet. She also had vegetations on a tricuspid valve, and this constellation of features allowed us to make the diagnosis of Libman-Sachs, or non-bacterial thrombotic endocarditis, which is an elderly woman with a predisposing condition, such as in this case, lung cancer. Other people have predisposing conditions such as autoimmune diseases, and they typically get very large, bulky vegetations, but they have no fevers, they have negative cultures, and that's what allowed us to arrive at the diagnosis. And then she was treated with chemotherapy and antithrombotics with Lovenox, and then she improved after that. Those vegetations resolved. Another case where we used imaging for a patient was somebody who had ventricular tachycardia. This is a patient with an LVAD for non-ischemic cardiomyopathy who had received multiple ICD shocks of ventricular tachycardia, and therefore our EP team decided to ablate the ventricular tachycardia. They put in a catheter into the heart retrogradely via the aorta into the left ventricle and approached the basal inferior lateral wall of the left ventricle where the VT was mapped from, and they applied radiofrequency energy to burn that lesion, burn the area from where the VT was coming, and the procedure was successful. Next day, she was feeling okay, but had a low-grade fever and some pleuritic chest pain, so we obtained a transthoracic echo, and you can see there's now a mass-like structure next to where the ablation was done. And so we weren't sure if this was a pseudoaneurysm, because when you're applying a burn, you can perforate that heart, especially if it's thin scar tissue, or if this was a thrombus or something else. And she can't undergo an MRI because she has an LVAD, so we opted to do a CT scan in her. This was a cine CT done retrospectively. You can see the LVAD, but you can very nicely see the hyperdense mass along the basal left ventricular wall. And so this was confirmed to be a thrombus at a Hounsfield unit of 20, and we can confirm that there's no perforation. And so this was very useful in deciding management. If it was a perforation, she would have gone for surgery, but we instead put on anticoagulation, and then within a month, this thrombus resolved and she did well. So again, it goes to show you how multiple lines of imaging can aid you in treatment decisions, whereas one test alone sometimes may not be sufficient. Talking about LV masses, we'll continue. There's one more patient I saw who had chronic myelomonocytic leukemia, and he had presented with fever and right heart failure, and his white count was 54,000 with 55% eosinophils. He has no history of travel to the tropics, and this is what his echo looked like. He's got an apical filling defect on contrast, and his apex is akinetic, but it's also thickened. His base is moving well. So is this another Takotsubo? Well, we wanted to investigate further, so we got a cardiac MRI, which really shows you that there's some sort of mass infiltrating the apex over there, and it's a very dyskinetic apex. And on first pass perfusion, this area doesn't fill with gadolinium contrast. So we're thinking now it's a thrombus that's lining the apical wall of the left ventricle, and we can prove that by doing late gadolinium imaging, where you see this white is fibrosis, and on top of that, that black line is thrombosis. And so this patient actually had Loeffler endocarditis, which is, this MRI appearance is very typical. You have a V-shaped pattern where you have a fibrous tissue, and on top of that, you have a cap of thrombus. And so this is what this gentleman had, and he was treated with anticoagulation and imatinib, and then this resolved. So again, the power of multiple modalities to come to the correct diagnosis. I think I'll do one or two more cases in the interest of time, and then I'll take questions from the audience if there are any. So here's an older woman with heart failure. She's 85, and she was seen for paroxysmal AFib, started on warfarin and weight control. At that time, her echo showed ejection fraction of 60% with grade 3 diastolic dysfunction. And a few months later, she had worsened. She was having more shortness of breath. A perfusion scan to rule out ischemia was done, which showed no defect. Her EKG is rather unremarkable. Her echocardiogram showed a thick left ventricular wall, small pericardial effusion, and a very abnormal diastology with high left atrial filling pressures. And when we do strain, you can see that the apex of the left ventricle is spared, has normal strain values, and the basal segments of the left ventricle have very abnormal strain. And this pattern, called the cherry on top pattern, makes us think of amyloidosis. And do you stop there for amyloidosis? Can you assume this is amyloidosis? No, you always want to rule out monoclonal protein. And so she underwent free light chain testing and immunofixation electrophoresis. Remember, don't do just an SPEP and UPEP, which can miss 20% of cases. So have your lab do not just the electrophoresis, but the immunofixation part of it, which will allow you to get more sensitivity. And then she underwent an MRI, which again confirms those findings. Very large atria, small ventricles, thick heart, and in this case, a depressed ejection fraction, small pericardial effusion, thickened interatrial septum. These findings are very classic for cardiac amyloidosis. And when you do late gadolinium enhancement, you see LGE in both ventricles, diffusely, transmurally, but also in the atria. And so the next step was to do a Pyp scan. This is a nuclear technetium pyrophosphate scan, where the heart lights up in people who have transthyretin in the heart, and you can measure the ratio of the heart to the contralateral lung, and her ratio is very high at 1.6. Anything about 1.4, 1.5 is abnormal. And so this allows you to non-invasively make a diagnosis of transthyretin cardiac amyloidosis, which is what she had. And we even tested her for a gene mutation. She was negative for that, so she had wild-type TTR cardiac amyloid. She was started on tafamidis, which is a stabilizer of TTR. And MRI, again, is very useful, not just in making the diagnosis in these people, but also for following them up serially after treatment with tafamidis, So here you can see something called mapping, which is T1 mapping, which allows you to probe the structure of the myocardium. T1 is very high in patients with amyloidosis. They also have very high extracellular volume, labeled ECV. And after treatment, the extracellular volume will go down in these people. So a normal ECV is about 25% because of expansion of the interstitium of the heart. With amyloid fibrils, it can go up to as high as 50%, and you can serially track these people to see if that ECV is going down, and the ones where it responds, they have a better prognosis. This is data from the pivotal trial called the TRACK trial, studying the role of tafamidis in these people where it reduced mortality. This was the first trial to ever show a drug reduces all-cause mortality in HFpEF. You remember in HFrEF, in reduced ejection fraction, we have ACE inhibitors, we have Entresto, beta blockers that reduce mortality, but when it comes to HFpEF, we really don't have any drugs that reduce mortality. For this subcategory of HFpEF, namely cardiac amyloidosis, we now have a drug that reduces mortality, and we are gearing up to get involved in a trial looking at another RNA therapeutic in this disease. This is called vutrisiran. It's a subcutaneous injection that is given once every 3 months, and it's a small interfering RNA molecule that prevents the translation of your TTR mRNA, and so thereby prevents amyloidogenesis. And it's hoped that with the knockdown of the TTR in these individuals, their cardiomyopathy will improve. I'm going to skip over some of the slides. We see a lot of patients with cardiac sarcoidosis. Here's a case of sarcoid again that was worked up with MR, FDG PET, and we see patients with Fabry disease. I was just telling Dr. Kruger on a drive here that we have a lot of patients in Chicago. We've established a center of excellence with Fabry. We have about 40 families that come and see us now, and we're doing a couple of trials in this space looking at not just enzyme replacement therapy, but oral therapy with a drug called lucerastat that prevents the formation of GB3. And I won't spend too much time on these in the interest of time, but we have a very robust infiltrative cardiac disease program. And I think, as I showed you, HFpEF is really becoming a larger chunk of the pie now. About 20, 30 years ago, most of the heart failure patients we saw had reduced ejection fraction. Now it's the opposite. About 70% of our patients have HFpEF. The EF is preserved, but they still have heart failure. And a lot of these people have these infiltrative diseases. So it's important to recognize this and have a center that can address this, both in imaging as well as in treatment. I want to talk a little bit about cardiac MRI perfusion. We use not just PET imaging, we use MR perfusion with stress testing. We use regadenoson stress test done with MR. So instead of using a nuclear compound, we use gadolinium. And we look at perfusion of the heart. Here you'll see that there's hypoperfusion of the inferior wall, and that can be correlated with CAP. This gentleman actually had 2-vessel disease in the anterior ischemia and inferior ischemia on the stress MR and underwent CABG. But not just in epicardial disease, we've employed MRI in syndrome X, or coronary microvascular dysfunction. This is typically seen in middle-aged to older women who have recurrent bouts of angina, and they undergo angiograms, and angiograms are normal when they're told, well, it's in your head, or you have fibromyalgia, or you have esophageal spasm. But now we have tools to actually look not just at the epicardial arteries, but at the microvasculature to see if there's problems with perfusion in the microvasculature. And you can do that with MRI using the microvascular perfusion reserve. And for those people who have an abnormal reserve, their cardiac event rates are higher than those who have a normal reserve. I think we're getting to the end of my talk. I think I'll stop here and take any questions, because I have plenty of cases to share, but I just wanted to give you an idea of what kind of things we're able to achieve with advanced imaging.
Jason, may I have a couple of questions, please? Jason?
Definitely. Go ahead, Dr. Sohi.
First of all, Dr. Kalra, this was a wonderful, great talk. I enjoyed it. You covered it very nicely. I hope our fellows were listening. We have discussed some of these things, but hearing from an expert it makes a better sense. When I tell them all this, they just ignore it sometimes. Two quick questions. One is coronary calcium. If you do coronary calcium in your doctor patient, for example, you will find some calcium, his LDL is 70. And now you have given them coronary artery disease. They're thinking about it all the time. Do you treat them anyway, whether they make the code or not? You say LDL should be below 50 or 30 or 40. Would you not treat the doctor anyway, though his calcium score may be low?
So I followed the part up until, if you see calcium, do I label them as coronary disease? Well, it's a label of non-obstructive coronary disease. So the presence of calcium does not connote obstructive coronary disease unless the calcium is very high. So when the calcium score is over 400 or 1,000, then your probability of obstructive disease rises. But I make it a point when I'm reporting calcium scores to tell the referring doctor this doesn't mean that they have ischemic coronary disease. They have plaque, and the plaque may be obstructive, but that depends on symptoms and if you want to do a coronary CTA. But we treat them with statins and aggressive lifestyle modification. Was there a follow-up to that question? I'm sorry, I missed the latter part of it.
No, that's fine. That's good. The other is about CTA.
Yeah.
Unfortunately, CTA needs a large hospital, people who can read them. CTA is not available to most of the community hospitals in this country. So they still end up doing cardiac catheterization. Even in our group, we're doing cardiac catheterizations. Our CTA is not well established. Hopefully, it will get better. So using CTA instead of cardiac catheterization has not gotten off the ground yet.
Yeah.
That's what I know.
Yeah. So what you bring up is very interesting. And so about 3 years ago, we put together a task force for the way I want to say it is democratization of CT or expansion of CT in community hospitals. And the Society for Cardiovascular Ct has really done a good job at educating cardiologists and referring doctors about CT. But as you know, American medicine is driven by what reimburses well, and there's all kinds of incentives that go in that. But if you look at Europe and other countries where the clinical power of CT has been shown, it's better than getting stress testing because it can lower your risk of heart attack and MI in your patients, MI and cardiovascular death. It's a no-brainer that CTA should be first choice. In fact, the new set of guidelines will likely include it, which I hope will lead to an expansion. I don't think people should get stuck in the groin and diagnostic angiograms to be told that it's normal. If that was me, I would be upset. I'm like, why couldn't you tell me normal without putting a catheter in my heart? So I think the cath lab should be used as an interventional lab, not as a fishing expedition diagnostic lab. And that's a viewpoint that a lot of the younger cardiologists who are trained in these imaging techniques share. I think that's going to take some time to shift that needle.
Thank you very much.
You're welcome.
All right. And if anyone has any more questions, you can either, if you want to unmute your mic and you can ask it, or if you would like, you can post it in the chat area and I can read it for Dr. Kalra. So if anyone has any questions. Don't miss your chance. In that case, Dr. Kalra, looks like you gave such a great presentation. You covered all the bases. So, but thank you so much for a great presentation, and we're happy you're here to visit and hopefully stay a little longer at some point. But one thing, just before we wrap up, we have a tradition here at the UofL Department of Medicine, going back several years now, that we present a little gift to our guest speakers, something that's very familiar. That's very familiar to the city of Louisville, and really that's nationally known. So check your, you'll be getting, UPS will be bringing you in just a little bit your very own Louisville Slugger bat.
Jason, can I say something? Jason?
Yeah, yes, go ahead,
Thank
Dr.
you.
Sohi.
Dr. Kalra, next time bring your family and your kids and come and visit our family. So chat with me. Come and bring your family next time. Come to our home.
Thank you. Thank you. We'd love that. Thank you. I appreciate it.
So we will, you will get this, and like I said, UPS will be bringing it to you here sometime next week probably. So, but yeah, it's a little gesture we like to extend to all of our guest speakers, and we hope you enjoy it. And again, thank you for an outstanding presentation, and I hope you have a great rest of the day checking out our beautiful campus down here in Louisville, and meeting some very nice people. So
Thank you. Thank
And,
you. I'll be sure to be slugging away.
definitely, absolutely.
Smack those coronary plaques out. Thank you very, very much. That was fantastic. Wonderful, wonderful, intriguing presentation. I think we all learned a ton. Thank you very, very much.
Thank you. Thank you.
See you all next week, okay?